I'm going to take over and we're going to start if that's okay.
Take
with
over,
everybody.
Minister.
Okay. All right. Araceli, we good?
Yes, all set
right.
to start.
All right. Welcome, everyone. Good afternoon. Good morning for those of you on the earlier time zone. I am extremely pleased to welcome such distinguished panelists and guests today, and friends and colleagues to our Center for Health Equity Transformation at Northwestern University, Chet Voices Talk, Chat, and also co-sponsored by the NYU School of Nursing, Rory School, Meyers School of College of Nursing, and also the Institute for Health Policy and Aging Research at Rutgers University. So I'm going to introduce all of the panelists, all four up front, and then Dr. Dzau will give a brief talk, and then we'll start with questions. First of all, Dr. Victor Dzau is the president of the National Academy of Medicine, formerly the Institute of Medicine. In addition, he serves as vice chair of the National Research Council. Dr. Dzau is Chancellor Emeritus and James B. Duke Distinguished Professor of Medicine at Duke University and the past president and CEO of the Duke University Health System. Previously, Dr. Dzau was the Hershey Professor of Theory and Practice of Medicine and the Chair of Medicine at Harvard's Medical School's Brigham and Women's Hospital, as well as the Bloomfield Professor and Chairman of the Department of Medicine at Stanford. Dr. Dzau is an internationally acclaimed physician scientist and leader whose work has improved health and medicine in the United States and globally. His seminal work in cardiovascular medicine and genetics laid the foundation for the development of the class of life-saving drugs known as ACE inhibitors, used globally to treat hypertension and heart failure. Dr. Dzau pioneered gene therapy for vascular disease and was the first to introduce DNA decoy molecules in humans in vivo. His pioneering research in cardiac regeneration led to paracrine hypothesis of stem cell action and his recent strategy of direct cardiac reprogramming using microRNA. He maintains an active NIH-funded research laboratory. At the NAM, he has led important initiatives such as Vital Detections for Health and Healthcare, the Action Collaborative on Clinician Wellbeing and Resilience, the Culture of Health Program, and the Grand Challenge in Climate Change and Human Health and Equity. Born in Shanghai and reared in Hong Kong, he is a champion for AAPI-NH community, and he has spoken about issues facing the AAPI-NH community at different venues, including the inaugural Vivek H. Murthy Distinguished Lecture Series for Public Health Leadership and the Chinese Academy of Medical Sciences. He has written about the need for diversity and inclusiveness in healthcare leadership and received the Asian American Engineer of the Year Distinguished Lifetime Achievement Award. Dr. Vivian Cheung is the Frederick G.L. Huetwell Professor of Pediatrics at the University of Michigan. She is an RNA biologist and child neurologist. Her lab, which is heavily funded, studies RNA processing in human cells and in the basic mechanisms that contribute to variation in gene expression in normal physiologic conditions and in response to stress. Dr. Cheung is a recipient of the Kurt Stern Award from the American Society of Human Genetics. She is a member of the National Academy of Medicine. She served as the president of the American Society for Clinical Investigation in 2016 and is one of the founders of the Physician Scientist Support Foundation. Dr. Cheung is a determined advocate for diverse biomedical workforce. Dr. Thomas Lee is the Chief Medical Officer for Ganey and an internist who practices as Brigham and Women's Hospital in Boston, Massachusetts. He is on the faculty at Harvard Medical School and Harvard School of Public Health. He is the editor-in-chief of NEJM, New England Journal of Medicine Catalyst, and is a member of the editorial board of the New England Journal of Medicine. He is a member of the board of directors of Geisinger Health Systems and chair of the board of Geisinger Health Plan. He is also a member of the board of fellows of Weill Cornell Medical College and a panel of health advisors of the Congressional Budget Office. He received his BA from Harvard College and his MD from Cornell, and he trained in internal medicine and cardiology at Brigham and Women's, and he received a master's in science and epidemiology from Harvard School of Public Health. Before joining Ganey, he was the network president for Partners Healthcare System. Dr. Bei Wu is the Dean's Professor in Global Health and Vice Dean for Research at the NYU Rory Meyers College of Nursing. She is an inaugural co-director of the NYU Aging Incubator. Prior to joining NYU, she was the Pauline Gratz Professor of Nursing at Duke University School of Nursing. Dr. Wu is an internationally known leader in gerontology. Her extensive publications cover a wide range of topics related to aging and global health, including oral health, long-term healthcare, dementia, and caregiving. As the PI, Dr. Wu has led significant number of projects funded by the National Institutes of Health. She is currently leading several NIH-funded projects, including a clinical trial to improve oral health for persons with cognitive impairment. She also co-leads the NIMHD-funded Rutgers NYU Center for Asian Health Promotion and Equity. Through this center, she leads a 5-year intervention study focusing on Chinese and Korean dementia caregivers who are at increased risk for high blood pressure and diabetes due to physical and emotional demands of caregiving. She also co-leads the Research and Education Core for the NIA-funded Asian Resource Center for Minority Health and Aging Research, and she is a fellow of the Gerontological Society of America, Academy for Gerontology and Higher Education, and the New York Academy of Medicine. She is also an honorary member of the Honor Society of Nursing, Sigma Theta Tau International. And I am going to hand it over to Dr. Dzau. What an amazing star-studded panel. Dr. Dzau.
Thank you, Melissa. You're quite amazing yourself. And it's daunting when I hear the bios of my colleagues, that my good friends Tom Lee, Vivian, Cheung, and Bai Wu. It's wonderful to be on the panel with them. Melissa, thank you for organizing this meeting. Northwestern, your Center for Health Equity Transformation, partnering along with Rutgers and NYU. It's a really important meeting. I would say that given this month, the Heritage Month for Asian American Pacific Islanders, there's lots now to celebrate, but a lot more work to be done. You asked me to give a 10-minute overview on this topic. I'm going to cover the challenges facing the Asian American Pacific Islander and Native Hawaiian population, but particularly talk about healthcare leadership. First, I would like to recognize there's much less data on NHPI, so my talk will tend to be heavier on Asian Americans. So may I have the next slide, please? So what do we know about Asian Americans, Pacific Islander, and Native Hawaiians? Well, according to the 2020 Census Bureau, Asian Americans about 6% of the nation's population, and NHPI about 0.5%, all told 6.5 to 7% of the population. We are indeed a minority. And when people think about Asian American community, they think of us as the model minority, better educated, better income, keep out of trouble, and being good citizen. But I think we all know this characterization is certainly incorrect. The group is hardly monolithic. It represents people from more than 30 countries, Asian Americans, each with its own unique history, culture, and language. And while it's true that the census data show Asians as a whole tend to be less living in poverty, that is 12% versus 15% of US population, I think it's stereotyping, because we do know large numbers are poor, vulnerable, living in Chinatown and elsewhere. And when you begin to disaggregate the data by subgroups, they show that 28% of Hmong, 33% Bhutanese, 35% Burmese Americans live in poverty. And also there are lots of language and literacy barriers. Believe it or not, almost 60% Asian Americans are born outside the United States, and almost a third having difficulty with English. And finally, out of almost 11 million undocumented immigrants in the US, about 14% are from Asia. Next slide. Now, what do we know about their health? Again, so much less is known in NH and PI population. But as a whole, we do know more about Asian Americans. And it's been said to be, well, there are fewer health problems to other minority groups, which is not true. Asian Americans are at risk for cancer, heart disease, stroke, accidents, and diabetes. And we also know that there's a high prevalence of and risk factors for COPD, hepatitis B, HIV, smoking, TB, and liver disease. And as you can see, and particularly in 2019, TB was 33 times more common among Asians. And of course, compared to white, which is 16% and 0.5 for the non-Hispanic population, pardon me. And so if you look at Native Hawaiian and Pacific Islanders, they do have high risk of viral hepatitis, HIV, STD, and others. But there's so little data on the subpopulations, because when you look deeper into the Asian American population, we know that Indian, South Asians have high incidence diabetes, heart disease. Tremendous increase. Filipinos are greater risk for chronic conditions like heart disease, and Chinese, liver, gastric, and oropharyngeal cancer. Next slide. So when it came to COVID, again, there's not a huge amount of systematic data collection, but it appears that COVID to be more disproportionately affecting Asian Americans, because when you look at case fatality rate, it appears to be higher than the overall population. If you look at California, the CFR is 3 times higher than the overall population in California, and exceeds 10% in Los Angeles, Chicago, New York City, New Jersey. Now, case fatality rate does not reflect the population infection rate, which tend to be lower in Asian Americans. For example, Asian Americans comprise only 12% of positive rates in San Francisco, despite making up about half of the deaths there. Now, why is that so? Well, Asian Americans, particularly those less educated, experience more job loss during pandemic. For example, the sectors where AA and NHPI are overrepresented, food industry, accommodation services, 1 in 4 are Asian American owned, and nearly 1 in 5 retail businesses are Asian American owned. Asian Americans also have a greater share of frontline and essential workers, especially in healthcare. So I think we all recognize there's a lot of disparity in the data. There's insufficient data, and there's certainly not enough data to disaggregate the information. Next slide. So this slide is really interesting because this is the only slide I can find in which a study by Marcello in New York look at urban safety net hospital system in New York City and look at 85,000 adults through March 1st to May 31st, 2020, of which about 10,000 Asian patients were there. You can see that all Asians are in purple, South Asians are in blue, and Chinese are in red, other Asians are lavender, white patients are in orange, and Hispanic in yellow, and Black patients in green. Well, you can quickly see that, in fact, we're not all the same. South Asian patients, that's in blue, have highest rate of COVID positivity and hospitalization, 31% and 51%. Second overall only to Hispanic and non-Hispanic Black. Chinese patients in red have high mortality of 35.7%, highest of all Asian ethnic group. I can go on, but I think you get the point. There's a need to disaggregate data. And one of the things we have found, certainly looking at COVID effect on vulnerable communities, is the lack of disaggregation and the thinking that we're all alike, which is hardly true. So in that regard, next slide, I believe that we are we're not getting the attention we deserve. As you can see, even Politico says how the vaccine campaign overlooks Asian Americans. And Health Affairs says mutually reinforcing cycle, poor data and quality, racialized stereotype that shapes Asian American health. And I'm embarrassed to say that National Academy of Science, Engineering, and Medicine, in our report on framework for equitable allocation vaccine, COVID-19 vaccine, we did not mention Asian Americans. Next slide. We also know that, of course, during this time, there is an increased anti-Asian American racism, particularly this past 2 years. Next slide. And you know that anti-Asian racism dates back to 1850s, plus years of exclusionary policy. But if you look at during COVID, some of our leaders, certainly in last administration, used words like China virus, Wuhan virus, and others, which is certainly inflammatory. And the false perception among Asians with illness coupled with xenophobic politicization have fueled hate crimes against Asians. The most recent analysis showed that anti-Asian hate crimes rose by 340% in 2021 compared to 2020. And we all know about the Atlanta shooting and others. Next slide. So my question is, for this audience, how can we contribute? First, as community members of society, we have to eliminate structural inequities in social determinants of health through investment in Asian American organizations, grassroots efforts, and multi-sectoral partnership. We have to speak up, as my panelists and I are doing, as you are doing, to increase awareness of this problem. We need more political representation. We have the lowest degree of representation in US political office compared to any other Asian group, according to NPR. Also, as researchers, we need a lot more research on AAPI-NH. We need more inclusion in clinical research, and we need more data disaggregation. And as clinicians and health leaders, we need to reach out to our own communities and our patients to have trust, communication, cultural competence, and ensure access and equity in healthcare. Next slide. So look at this data. We're the most understudied US racial ethnic minority group. 0.2% of federal health grants are on Asian Americans, Native Hawaiians, and Pacific Islanders. 0.71% of NIH grant on ANPH health. And Medline search looking at articles over a period of time shows 0.01% articles include any Asian Americans in study sample. We are not represented. We need to recruit a lot more of us into these studies and be represented. Next slide. And as community members, we need to develop trust, address social determinants of health, bolster community capacity through investment, strengthen transformation coalition with other racial groups, speak up, and we need to have leadership representation. Next slide. So that leads to this whole conversation about leaders. There are not enough of us in leaders. We're underrepresented in positions of senior positions of influence, companies, politics, and media, and other realms. Holding only about 3% of these positions in comparison with composing 7% of the population. And as Larry Tabak has written recently, while AA and NHPI individuals represent 20% NIH workforce, they represent senior positions to be lagging behind in the overall workforce. Next slide. So my good friends, Tom Lee, Vivian Cheung, and Kevin Volk wrote this article in New England Journal of Medicine Catalyst. The four of us start talking about this issue and decided that we're going to look into data, and thank Tom Lee, particularly Leapfrog, for putting a lot of data based on US News Report ranking, many others, to show that number one, while we are 20% of the medical school population, 23, and 20% of US physicians, we represent 6% of hospital leadership and 13% of medical school leadership. Totally disproportionate. Next slide. And I'm sure that we're going to talk about this, so I'm not going to spend too much time, except to say from this paper and from other studies, we know there's a bamboo ceiling. I would say that the issue is certainly the quote in the second sub-bullet. We are perceived as smart, hardworking, easy to manage, but the model is that we are good workers, but not great leaders. And I'm sure we can talk about this. The Russell Reynolds Associates, which is a headhunting firm, has studied this and say that what are the characteristics of C-suite leadership? They call them soft and loud qualities. Soft qualities are pragmatic, reluctant, vulnerable, connecting. Loud are disruptive, risk-taking, heroic, and galvanizing. And guess what? US space executives tend to be score highly on the loud qualities. And that's what people, when they look for leadership, look for. Whereas we are more reflective, more thoughtfulness. These are strong leadership qualities, but it's frequently overlooked. And I'm sure Vivian and Tom and Bei will talk about their point of view on this. Next slide. Even in research, we make about 7% population, but with 40% of highly cited scientists, 25% of NIH grant recipient, 7% of HHMI investigators, and guess what? Hardly included in the major awards, less than 1% of prizes. Lasker, Breakthrough Prize, Nobel, of course, Gruber Prize, and you name it. So science and health leadership. Next slide. So I want to end by saying we have certainly seen that COVID has disproportionately affected us, and there's a rise in anti-Asian racism. Also aggravated mental health disorders and burnout among our population as others. It's imperative to address these issues and to overcome bias increasing the leadership in health and science for Asian American and Native Hawaiians and Pacific Islanders. Final slide. Well, there is certainly progress being made. First of all, it's really great to see executive order from our president advancing equity, justice, opportunity for Asian Americans, Native Hawaiians, and Pacific Islanders. We at the Academy finally have a workshop looking at health equity among Asian Americans, Pacific Islanders, and Native communities. NIH have requests for information seeking more actionable input to improve research in this area. NIH have now put forward, as you know, in May, the inaugural annual NIH AA-NHPI Health Research Conference on an ongoing basis. I was fortunate to speak there with Howard Cole. You have the Tri-Institution panel today on leadership. And guess what? This afternoon, I'm going to speak to the nurses of API on the future of nursing and healthcare. But we all recognize there's a lot more needs to be done. And I know we're here to talk about this. And I'm so privileged to be joining all of you. Thank you.
Thank you so much, Dr. Dzau. That was incredible, very spot on. Let's start off. Doctors Lee and Dr. Cheung, if you can please tell us, why is this topic so important right now?
Well, I would start by saying the truth is it's always been important, but we're tuned more into it now than ever before. And as Victor knows, I first met Victor in 1978, December, when I was interviewing at the Brigham, and Victor was the chief resident, and I stopped him to say he was the first Chinese chief resident that I'd seen anywhere. And I said, what was that like? And Victor told me how he felt it was a real meritocracy there. But like just meeting Victor and seeing that an Asian, Chinese person like me could become the chief resident, that was a new experience. And it was the reason I listed the Brigham #1, because I felt like, okay, I could fit in here and you could do anything here. And giving that message that, yes, you belong here. The doors will be open if you work hard, and which was what Victor said. Victor said, if you work hard here, if you're bright and you work hard, things will go fine for you here. Giving that message is a wonderful thing to do for everyone, not just for Asians, but we need to give that message to everyone. And having a diverse leadership team is essential, I think, to making people feel like, yes, I belong here. Yes, I have opportunity.
Dr. Cheung.
Yeah, I thought exactly what Dr. Lee said. I think having role models are really important. I think was clued into this question when a student came to me. She was getting an MD PhD in computer science. And she said, you know, I have a problem. I've studied the faculty at the university, and as a woman, as an Asian woman, my chance of becoming a professor and a leader in the university is less than 1%. And what should I do? Right? And I think that moment was, you know, woke me up to think about, in many ways, it is my job and everyone's job to create an environment where people in the leadership position, as Dr. Lee said, is diverse so that everyone has a role model.
Thank you. Dr. Wu, so as an Asian, what do you think of the notion of being a model minority? And you think there's some relationship between this and this bamboo ceiling?
Thank you, Dr. Simon. And as Dr. Dzau mentioned, the notion of a model minority is certainly a stereotype. And this is I call this also as a picture incomplete. When you look at those individuals, yes, many Asians have a high socioeconomic status that and better health outcomes than many population groups in the nation. But certainly this kind of stereotypes of Asians are such a heterogeneous group of people, a very diverse background, and also that many Asians are immigrant that with different kind of immigration patterns. So that is a very complex group of people. But one and the several issues that kind of fit into this notion of a minority is certainly, as Dr. Dzau mentioned, the lack of a national representation of Asian American and the Pacific Islanders in large data sets. Now, our group has conducted many large kind of data analysis using large data sets, but unfortunately, all these looking at all these large data sets are only limited to individuals who can speak decent English, that or actually like in either conducting English or conducting Spanish, so that those individuals who cannot speak decent English can be systematically kind of excluded from this population. So almost think about the more data set, the results you generate from this data set, you kind of more emphasis and highlight this kind of the notion of model minority. But certainly this is quite a biased sample. And also the potential that potential exclusion of these English individuals with limited English capacity. And also this underdocumented population as well. Asian population is almost kind of very diverse in kind of population and at the both kind of end, think about spectrum wise. And also lack of disaggregated data for ethnic groups, that large data sets, it's very hard for us, like for our team to look into data and only find, for example, that the national data set, enhanced or national health interview survey, so looking at Chinese American, Indian Americans, or Filipinos, then others, everything, every group is going to kind of other Asian groups. So while Dr. Dzau was making a presentation, I put out just one recent study that currently is under review, look at the vaccination rate across racial ethnic groups in the nation. We'll look at BRFS data that including respondent close to 400,000 individuals. Interestingly, even for BRFS data, we know that it can systematically exclude some individuals with limited English capacity. But when you look at these kind of age groups, we divided this age group between like from age 18 to 88, because that's the kind of age cap there. Very interestingly, Asian population compared to other groups, yes, at the other kind of younger population, they have a higher vaccination rate. However, at the age 80 to 88, it's a switch, that it's only 69% of the Asian older adults, 80 to 88, had the vaccination, compared to 84 white population and 89 Black population. But certainly Hispanics are much lower, 41%. So between Asian and Hispanics at this, the oldest old group, which needs to have the vaccination rate, vaccination that much in need, but they actually have a much lower rate than white and Black. So that's a kind of interesting one for those, even that for included individuals in the BIFFs, we already see disparities within all the Asian groups compared to other groups. So that's what I think the notion of minority, kind of modern minority, there's a lot of kind of data issues. We need to really, when I had the honor to present at the NIH first inaugural AAPI Health conference, I made this point. Later, actually, they invited me to give a separate talk to NIH program officer was last week. I made this point again. We need more data to include more Asian populations. Maybe actually to have to find a small the study with small data set first, and we're using mixed methods and potentially find some clinical trials that focus on Asian Americans that to begin with. So I just end up here. Thank you.
Yeah, for sure. This model minority myth is pervasive across everything, whether it's looking at assuming, making assumptions and biases about perpetuating biases about education, biases about health status, being like what you just said, Dr. Wu. And, you know, if you don't characterize it through data or capture it through data, then you don't know, right? And then people just kind of sweep it under the rug and perpetuate these biases and stereotypes, and especially true in the leadership. I have, you know, other than what Dr. Dzau and Cheung and Lee have written over the last few years, and also a few other authors, you haven't seen in the published literature data around leadership. And, you know, as a wife of somebody from China who is a physician scientist and leader, I was astounded by the lack of Asian representation in higher level leadership across health systems and academic medical centers and universities, and compared to the workforce. So I'm going to pivot and say, so what are some of the barriers for Asian Americans to be successful leaders? And are these barriers different for different sectors? And then what specific barriers do you see in becoming successful leaders across these sectors?
Hey, Melissa, I'd like my colleagues to obviously answer because I already gave my speech, but I do want to emphasize what Bei said. You know, if you look at the date of vaccination, that you quickly ask the question, why are elderly less vaccinated? The issue of trust, language, culture comes into play. And that's where the interventions can occur. In other words, it's not just studying the information to say we need more information, but it can allow us to understand the problem and being able to intervene by focusing on this population to gain trust to get vaccination. So thank you. I'm sorry to interrupt your question. Very important one.
It's okay. You can answer the question too.
No, I'm going to ask the others to do so.
Okay.
Well, you know, I'm happy to jump in first, and you know, the table that Victor showed was showing that the Asians were just 6% of the C-suites in hospitals versus 20-25% of the workforce. That even, you know, if you go deeper and you segment by the subgroups of Asian, like East Asians, like Chinese, for example, like it was more like 1.5%. It was in, you know, so that, you know, they're more relatively more Indian Americans than East Asian Chinese Americans. Now, I think that there's an external, I'll just say there's an external issue, and then there's probably some internal issues for us to think about. You know, the external one, I would say that, you know, was best put by Ron Williams, who is an African-American, great former CEO of Aetna, very thoughtful man. And when he was looking at that data in that paper, he said to me, Tom, when organizations are doing well and they need to replace someone in a leadership role, they go to central casting and they look for someone who seems like the person who is retiring or has just left the organization. He says, they don't go looking for someone who looks like you or who looks like me. You know, they have an idea and they want to just continue. And he said, and that's the reason he tells people who are members of minority groups and including women, because they're underrepresented as well. He says, if you want your best chance of being appreciated for your strengths are to be ready to go to organizations that are not doing well, where they have to be ready to say, okay, who can actually do it? And not just who looks like the last person who was there. The second thing I would say is that sometimes, you know, like I think there are self-imposed stereotypes. And I think many of us who are Asian believe that, well, we don't really like conflict as much as like Americans are ready to embrace conflict. And, you know, that is something that's a stereotype that's out there. And there's some truth to every stereotype. The thing that I learned over time is that if you don't like conflict, you love conflict resolution. And that was something I only learned when I was sort of forced into management roles, that when I would go, that actually negotiating and working out, you know, a solution when parties have disagreements, that is a wonderful thing if you're someone who has a holistic view of the universe and the people involved, which I think many of us who are Asians do. So I would say that for any of the listeners who are thinking, I don't like conflict, I think that don't think that means you shouldn't be a leader. That actually means you might be great in a leadership role.
Dr. Cheung, anything to add?
Yeah, I think I'll add to that, that I think the minority tax is a real issue. We tend to volunteer a lot more and kind of take on a lot of more tasks as we advance in our careers. And I think those oftentimes kind of put us out of networking and other leadership opportunities. And that balance between saying yes to too many things and having a goal, I think, is important, especially for junior people.
Yeah, also that I would like to say that if you look at the Asian leaders in the nation, that also that the females are very much underrepresented in that. So, and the Asians, a lot of that Asians are immigrants. So think about that. We may facing there's a triple jeopardy here, being female, being Asian, and being immigrants. So that notion, and some also think about that we need to overcome all these kind of barriers to think about this. And also that that many people, and I'm sure that some of us has encountered that also question, look, at you are different from us in a nation, you're different from us. Some are also question potentially kind of underlying kind of things, the loyalty as well. That whether you the sense of loyalty to this country. So regardless of how long we have been in this country, we could that have the people will have the question. And sometimes even in the daily conversation, you will run into this, oh, that in your country was like, no, I'm your citizen. So that kind of essentially can be some barriers when we think about our career development.
Thank you all. So in each of your leadership positions, what's the most challenging thing that you've had to encounter, and how did you overcome this challenge?
I'll give it a try. We all talked about, I think Tom talked about the fact that our culture, our upbringing, certainly I was taught very different things until I came to this country, and I still feel that very much of what I was taught is part of me. That is indeed to stay out of trouble, keep your nose clean, and work hard. It's all true. So I think the difficult issue is being what's expected of you as American and American leader. So I will tell you a story. Even when I became the CEO of Duke Health System, I was told by some of the senior leaders that I wasn't quite like them. I don't talk about my personal issues. I don't open up enough. So we had a retreat and we did Myers-Briggs. And of course, Myers-Briggs tell you what kind of personality you are. To everybody's surprise, I was an introvert, even though I compensated over the years of being more American. And I think about why, because the question Myers-Briggs asks you, what would you do first if you confronted this situation? My instincts, my culture would be to do what I was brought up to do. But if you ask me the second question, what would you do to overcome this? I would say what I've done is basically overcome this over time. So I think that's a very important learning lesson, because I was going through some very difficult family issues at the time, and I was not willing to share with anybody I know. It's somewhat different than my other colleagues who are Caucasians, who are quite willing to talk about these issues. So I would say these are learning lessons which are very difficult in understanding that my own culture, I've always lived through this, and at the same time, the expectation is somewhat different.
Yeah, I'll bring up something that's analogous in a way, which is there's a socialization that occurs among many of the people who are in the C-suite now. And for me, is captured with the example of playing golf. I don't play golf. I don't want to play golf. I don't want to spend 5 hours wasting time. I want to get work done. And I would go insane if I had to play golf. So I have refused to play golf. Now, a lot happens out there on the golf course, and I'm not part of those interactions. Now, what I would say is I don't want anyone to have to learn to play golf, but I do think there is something I know that Victor has had to learn, I have had to learn to go into rooms and to work the room, even if it's not natural. I think we're both a little bit on the introvert side, but I think that we both learned that you have to be willing to walk around the room, talk to everyone, shake their hand, hear about their families, remember who their children are and what's going on with them. That is part of having multi-layered relationships with people, and that is part of leadership. I would rather be off on the side talking to someone who is really interesting in an area I was interested in, but working the room, if you want to be a leader, you've got to be ready to do that. I don't think you need to play golf, but I think we can have a randomized trial on that.
Well, then the intersectionality comes into play, because the only kind of golf I'm going to play is miniature golf.
Yeah.
That's it.
Takes less time.
Dr. Wu and Dr. Cheung, anything to add?
I think that intersectionality really is the issue, right? Like, I think if we ask people, imagine a leader, very few people out there will imagine an Asian woman. And to be able to find that identity and stand up and said, yes, maybe my leadership will be different and I would never play golf and such, like how to be able to find that inner self and have confidence with that inner self certainly is difficult, but achievable.
Yeah, surely achievable. As a Latina woman, I share your sentiment that, again, those of us here present are not the first picture that comes to most folks' mind as to who their next dean should look like, or their next CEO. Dr. Wu.
Yeah, and also, yes, well said, Dr. Lee, that there was such a kind of interesting thing that you shared, play golf. So does that mean that when we're trying to kind of climb the kind of career ladder, we all need to kind of learn play golf? So it was And also that, recently, and I just went through this kind of a job talk and as the vice dean for research, and at the Duke, I had a similar kind of experience. When you're trying to kind of apply for these kind of positions, that people, it's interesting, people ask you questions, think about, oh, gee, you already have kind of so much work to do. You're so heavily NIH funded, you're mentoring all that. So do you have the time to do this? So like, how are you going to manage this? So that kind of question came up to think about, is this kind of almost like you're taking on too much. So I wonder this kind of question would be asking for other people that, which is different from like other kind of male and Caucasian kind of individuals. So that's I found it's interesting phenomenon that I encountered several times during my career development phase.
Me too. Me
You
too.
know, Melissa,
absolutely.
I've heard from several friends and mentees that when they're looking at being searched for dean's job or some major leadership job, the question is, can you raise money? I think the implied question is, can you schmooze with everybody else? Are you like one of them? Right, Tom? I think we talked about this.
That's a huge issue. And the idea of asking people for money makes me want to throw up. But to run a great institution like a Duke, you know, you have to be ready to be part of those conversations and figure out how do you do it. And this is one reason why people play golf. So it's, you know, it's not like there's a simple, clean answer to these challenges. And so if you can play golf, you don't want to, then you'd better be ready to work with these people in some other way.
Right. Well, you know, I mean, to be fair, obviously we are working in this society and there are expectations and assets needed to do the job because you still have to cater to a majority expectation. That being said, I think what's lost is a sensitivity of the strength that we can bring to the table, which they do not see. But the issue that Tom, our paper said about Russell Reynolds, right? I think that's really well put.
Yeah.
In other words, leadership qualities can be defined in many different ways, but to define it only strictly by a certain bias excludes, as you said earlier, about conflict resolution and the skill set we can bring to the table, which can be really important. And I say that sometimes when we look at the problem we have in Congress, in our government, the people we believe can be good leaders to elect to the government to represent us, well, guess what? I'm not sure their skill set is fit for their leadership, quite frankly. We'll never be able to resolve anything to move forward for the common good if all we are looking at is who's got the bigger shoes and how do I stay in power.
Very well said. Couldn't agree more. So what would each of you tell your younger selves now, vis-a-vis then carrying some advice to the people on this presentation, on the Zoom?
Well, all right, so I'll jump in first, and again, I'll say that I'll say two things. You know, first, like I think everyone knows when they don't feel included, where like DEI, the I is conclusion, where they don't feel like they fully belong. I think what I've learned since in the last 2-3 years, which is it's virtually everyone other than white males have issues with feeling not fully included. And, you know, it's women, it's people with any kind of disability, you know, it's every race and ethnic group. And I think that using that insight of what it means to feel not included, to work hard to make everyone feel like they're part of an inclusive group, that's something that is, that's a strength that we can have. Because we know what it means to not feel included, we can be the most inclusive leaders, you know, available. The other thing I would say, which relates to something in the chat, which is that there is this stereotype about the model minority, we never burn out. And in fact, the data do show that Asians are much less likely to have burnout symptoms than other groups. But the fact is, there is burnout. There are mental health issues, and Asians don't necessarily seek it out as much, and it's reflected in suicide rates and so on. And I would say that, like, understanding that there are going to be mental health issues and having paths to address them is a very important part of the future as a parent, as a leader, and so on.
Dr. Cheung.
Yeah, I would say, like, to remember that oftentimes it's not the journey or the destination, but the people around us. And I certainly will not be where I am without surrounding by people who are supportive and able to see me for who I am. And so, yeah, surround yourself with good people.
Right. I would also add on to say that we all want to kind of, for those individuals who are seeking leadership, it is great, but also in the meantime, trying to establish your own program research to build the reputations as being an excellent scientist, as being an excellent physician. As Dr. Dzau was saying, that Dr. Dzau's kind of reputation first as a scientist, as a pioneer in his own kind of research. So then we can have the kind of, we set up our own as a role model, then can lead others. Mm-hmm.
If I may, Melissa, I think my colleagues are spot on in all their comments. I would say the following. Yes, we have to recognize there are differences and embrace the differences. We also have to recognize that we do live in a society, let's say there's quote norm, even though we need to change the norm. We need to understand that we can't just simply say, well, we've been undertreated, underrepresented, and we got to work towards it. Importantly, we do have to adapt, at the same time maintain our culture. So I think I always tell the young people, you have the best of both worlds. I mean, how many people have the fortune of being brought up in an Asian American background with heritage, with culture, at the same time being able to bring it now to this new world and being able to also adapt to the new world. It's reality. And certainly over the years, I've adapted to it. I think it's also really important to understand, as been said by Vivian and others, there are many good people, certainly who's given me an opportunity. Tom Lee talked about where I was at the Brigham. Well, we both know Jim Brownlaw, Marshall Wolf, who saw us for who we are and not what our color of our skin is. I think that we need to do the same for everyone around us to help them get there, right? And really speak up for all these issues and helping people, the younger generation, to understand this is a journey which we all have to go through. But as been pointed out, I think the end point is what we want to do most, which is being able to make a difference.
Thank you. Really well said. I know we only have a couple minutes left, but I want to have you each give some insight to high-level leaders. If you could speak to all the high-level leaders out there right now, what advice would you give them to help support them in finding and hiring diverse teams, adding API people to the team?
I'll just quote Clay Johnson, who was the CEO and dean at Dell Medical School, who I once heard him say he said, lack of diversity makes you stupid. And then he said, I hate being stupid. It's true, because everyone has blind spots, and you've got to be thinking about your team as a team, and you want the collectively to be no blind spots, or as few as possible. So having a diverse team and empowering people to speak up, that'll helps you avoid terrible mistakes.
Dr. Cheung?
I think I would say, like, we really do need leadership that represent the people that we serve, that every day that when we come to the job or that they go to the job, it's not about them. It's really about the people and the patients that we serve, and we have to represent them.
Right, and yes, that's is all well said. But also, in addition, that we said many kind of barriers. But as an immigrant myself, and came here in the kind of late 20s, I do think that to acknowledge this is a land of opportunity. That we are surrounded by many wonderful leaders and mentors. That's who actually make us here, being that in the United States. So.
Melissa, I really don't have anything to add. I think my colleague said it so well. I mean, to me, the future of this country rests in its diversity, equity, inclusion, or inclusiveness. We all know that, and everybody knows that. And so let's just go for it.
Yeah, check your biases at the front door when you sit and serve on search committees, first and foremost, right? All right. And when people are saying, is this really a person who could be our leader? Absolutely is the answer, almost always, if they're very different. Check your biases at the front door. I want to thank you all for taking the time today to join us and provide your amazing insights. You are all rock stars, and I am in awe of each of you. Really, thank you each for what you do. Thank you to the people who joined us to listen. We will have this posted on our website as a recording, and I wish you all a wonderful week. Thank you so much.
Thank you.
Thank you.
Thank you for inviting us.